Okay, good morning, everyone. I think we'll go ahead and get started now. We're expecting a few more people to join us, but I think we can start, and then they can come and join us as they wander in. So, good morning. Thank you, everyone, for joining us today for this community consultation on SRHR of women and LGBTIQ+ refugees and asylum seekers in Thailand. This consultation is actually the first of two consultations which will be looking at the unmet SRHR needs of women and LGBTIQ+ forcibly displaced persons in Bangkok by collecting evidence and generating advocacy initiatives. It's part of a project that's supported by the Julia Taft Fund and being implemented by Asia Pacific Alliance for Sexual and Reproductive Health and Rights, which is the organization I am working with, and the Equal Asia Foundation. So I think we all are familiar with the fact that in Thailand, the country is not a signatory to the UN Refugee Convention and does not recognize refugees, but rather categorizes them as undocumented individuals. And as such, they're regulated under the Thai Immigration Act. And so law enforcement treats refugees the same as anyone who does not have a legal document, which means deportation for those who are getting arrested. Forcibly displaced persons without legal documentation often get sent to immigration detention centers or IDCs, where they can remain for an undetermined amount of time. It could be days, weeks, or in some cases, even years. They can be subjected to assaults and harassments at the hands of law enforcement, both outside the IDCs, as well as inside by detention staff and even other detainees. Gender and identity-based harassment and physical violence is a regularity for women and LGBTIQ+ forcibly displaced persons. This is added on to the fact that they're often already going through psychological and physical stress from the abuse and discriminations that they've suffered both on their way to this country as well as from their countries that they're coming from. So it's a re-traumatization of them experiences. They're at a high risk for STD transmission, especially in IDCs, due to the overcrowding, sexual violence, drug use, and lack of appropriate health care. There's also been reported cases of sexual abuse against women, girls, LGBTIQ+ persons that have been committed in the IDC centers. Yet both inside and outside of the IDCs, women and LGBTIQ+ forcibly displaced persons often lack access to medical care, including SRHR. This includes access to suitable HIV and other STI treatment. PrEP is rarely made available for LGBT persons, and neither are menstrual supplies, access to safe abortion, other STD prevention initiatives. Because of that, HIV and other STDs are often 10 times higher in detention centers than the general population. So overall, the SRHR needs of women and LGBTIQ+ forcibly displaced persons are often overlooked because of the lack of attention that's been given to them, especially in this region of Southeast Asia, and it's creating a big sort of a blind spot in knowledge. And so we're here today to gather insights and share information to discuss strategies to improve SRHR and support for these communities. We really want it today to be a very interactive program. I think there's a lot of knowledge and expertise in this room, so we want to be able to have a good exchange and a lot of time for people to talk and discuss amongst yourselves on the agenda. I'm now going to pass over to Ryan, who is our partner, who will also share a few words. Welcome, Ryan.
Good morning, everyone. Good to see you, Alexa. My name is Ryan Figueredo. I use he, they pronouns, and I am the founder and executive director of Equal Asia Foundation, Asia's only LGBTIQ think tank and innovations incubator working on future scoping and future-proofing for LGBTI communities in the region. Unfortunately, I cannot be with you in person, but I'm grateful you could all come to this really important conversation. I'm also grateful for our partnership with the Asia Pacific Alliance for SRHR and for their leadership and advocacy in the region. We are a proud member of this network. This meeting, like Alexa said, is the first of this project, and it follows two important pieces of work that Equal Asia Foundation led, the first being a report on the plight of LGBT refugees in Thailand in 2020, and the other, a project on creating digital empathy for LGBTIQ refugees, and a film based on focused interviews with LGBTIQ refugee and asylum seekers who transited or are still in Thailand. We hope that in partnership with you, we will be able to fill some of the glaring gaps in understanding the SRHR needs of women and LGBTIQ refugees in Thailand and develop a manual for both LGBTIQ organizations and organizations working on SRHR that will deepen LGBTI inclusion in this space. There are a couple of things that are happening that make this conversation very, very important. We're entering a critical time for the Global Refugee Compact, which is the Global Refugee Forum 2023, where states and other actors are reviewing the progress of their pledges and crafting new ones that better reflect the challenges we are facing today. We just completed a workshop at UNHCR in Geneva last week on LGBTIQ inclusion for GRF pledges for diplomatic missions there. We're also going into the 7th Asia Pacific Population Conference, where the progress and implementation of the 2013 Asian and Pacific Ministerial Conference on Population Development and Plan of Action of ICPD, plus key actions in Asia and the Pacific in the context of the 2030 agenda will be reviewed. We are also, what Alexa said, in the early stages of implementation of the national screening mechanism, something that Amy Smith from Fortify Rights described as being effective only if they can identify and protect all potential refugees in Thailand. She also went on to add the national screening mechanism could be a significant opportunity for Thailand to reverse its dismal record on refugee rights, but will fall short of international standards and fail to achieve it if it arbitrarily excludes categories of potential refugees. Many of our colleagues here present understand what this exclusion will mean for healthcare provision for vulnerable persons. Also, if you are in this room today, you are no stranger to the challenges that LGBTI plus persons face in the region, and for that matter in this country. But the multiple and intersecting forms of vulnerability of LGBTIQ refugees and asylum seekers are perhaps not widely understood, and hence their needs are poorly met. We hope that together we can do more, and we really appreciate you for coming. I look forward to our conversation today, and I now hand over the virtual floor back to you, Alexa.
Thank you, Ryan, and thank you so much for taking the time to join us from overseas. It's been a busy time for you. I just wanted to take a second also to introduce one of the supporters of the project, Brett Walkley, who is the Deputy Regional Refugee at the U.S. Department of State. I don't know if you want to say just a quick word or two. Sure.
I'll just say thank you to Alexa and to Ryan, our partners on this project, and to everyone for coming. I hope it will benefit our understanding and the collective response for this population. So thanks again, and looking forward to it.
We're very glad that you joined us. I'm going to hand it over now to Shane, who is going to lead us in a quick introductory session.
Hi everyone. We're going to do a quick icebreaker. So it's gonna be very different from what you've done before, probably. But we're going to do a round of introductions of who is who, what your name is, what your organization is, and which cat you feel like today. So if you can see, there are like a few different moods of cats. So I'm going to pass the mic along and say your name, organization, keep it very short, and which cat you feel like.
Hello, good morning everyone. I am Shreyashi from Youth Lead, and I think I feel like cat number 4.
Thanks, Shreyashi. Good morning. My name is Ika. I'm working with Shreyashi at Youth Lead. I feel like I'm a cat number 6.
My name is Anne. I'm from Host International Thailand, and I will go for number 3.
I'm from China. Now I is 6. Yes.
My name is Summer. I'm from China, and I feel number 3 is me. Good morning. My name is Nantakan Woodham. I'm from Planned Parenthood Association of Thailand. I think me will be number 6. Hello, I'm Sunika Losamuntri from Planned Parenthood Association of Thailand. My cat is number 3 because I would like to know what's going on today.
Good morning, everyone. My name is Papaporn Chuet. You can call me Dream. I'm from Rak Thai Foundation. I like cat number 9 because I like its ear. Yeah.
My name is Narut Pidungchai from JRS, and I would be cat number 7. That's me after one drink.
Good morning, everyone. I'm Tim Moore from the Border Consortium, TBC. I want to be cat number 6, full of discovery and delight.
Hi, everybody. Brett Walkley from the U.S. Embassy. I want to be cat number 6 as well, but I often feel like cat number 8.
Good morning. I'm Phon Sarinya from U.S. Embassy. Go for number 7.
Good morning, everyone. My name is Supawadi Thongrit from JRS. So I think me gonna be a cat number 5, plus number 3. So
good morning, everyone. My name is Villa. I come from JRS. I like cat number 6.
So, good morning, everyone. My name is Nam from GRS. For me, I think I'm gonna go with cat number 5. Yeah.
All right, thank you, everyone. I'm going to introduce myself. My name is Shane. I'm from Equal Asia Foundation, and I feel like I'm all the cats. Yeah, so they all are alter egos. Thank you so much. I'll hand it back to Alexa, and she'll take it from here.
And my name is Alexa. I don't know if I fully introduced myself. I'm the director of the Asia Pacific Alliance for Sexual and Reproductive Health and Rights. I feel like number 3, but I kind of want to be number 4 right now. I'm still a bit sleepy. So moving right along, we actually now have a small presentation from an expert who's going to share a bit about sexual and reproductive health challenges faced by LGBTIQ refugees and asylum seekers. I'd like to introduce Maddie Chakrabarty, a researcher and development professional specializing in gender, forced migration, and South Asia, who's also joining us virtually. And they are going to provide an overview of the unique challenges and barriers faced by this community to obtaining and fulfilling their SRHR. Over to you, Maddie.
Thank you so much. Good morning, everybody. I'm just going to try and share my screen. And in case it's not possible, if somebody can help me, that'll be really great. Let me try again.
This is always the challenge with online.
Okay. Can everybody see this?
Yes, you just need to put it on presentation mode.
Slideshow, yeah. Good morning, everybody. So a little background to this research. It's mostly focusing on the needs, SRHR services needs of LGBTQI plus refugees and generally LGBTQI plus populations and their needs in forced migration, as well as that of women. So I'll start with a background of SRHR as a sort of source of human rights. So as we all know, SRHR are a host of rights that came about due to the tireless activism of feminists, including LGBT activists, largely from the global south, to challenge prevalent racist and misogynist notions around population control. Enshrined in instruments such as ICPD and the Yoga Karta principles, among others, SRHR enshrine the principles of bodily autonomy and integrity, along with safe and consensual sexual and reproductive practices. SRHR is broad and inclusive in its scope within international law. SRHR guarantees the principles of non-discrimination and equality, the right to health, the right to privacy, and the right to found a family, among others. Given the broad scope of SRHR in international human rights law and the current contestations from conservative, authoritarian, and anti-gender narratives, it is a clear avenue for practically broadening the substantive access and service provision for LGBT persons, including those in forced migration and humanitarian crisis context, as well as women, of course. In practice, however, especially within humanitarian crisis and emergencies context, SRHR is often deprioritized and remains mired in heteronormative tropes. So looking at international refugee laws and SRHR for marginalized community, there has been an increasing recognition of the particular need to focus on the needs of vulnerable communities such as LGBT migrants and asylum seekers. In a report that he published, the independent expert on sexual orientation and gender identity notes that LGBT communities are often vulnerable to physical and sexual violence, stigmatization, and criminalization, which leads to forced migration. And the particular needs of the community, including help needs, specific attention within the refugee governance and humanitarian sector. There are also multiple process documents and roundtables conducted by the UNHCR that have noted the need to make special accommodation for vulnerable LGBT refugees and migrants, particularly also their particular SRH needs, especially in context of HIV and STI prevention. Generally, in terms of research and data within the LGBT forced migrants within Asia, in the Asia-Pacific region is scant, and this is partly due to the lack of unambiguous substantive guarantees to equal rights of LGBT persons in this region, which largely sees forced migrants aspiring for asylum in global north countries. Another strand of literature with a lot of rich insights focuses on LGBT forced migrants from the MENA region, centered around the refugee governance system in place in Turkey. Even within this sort of formalized system, the literature reveals that in practice, the refugee status determination processes for LGBT persons are still mired in a lot of stigmatization and discrimination and poor understanding of culturally appropriate norms for people from the region. So Thailand remains one of the most popular destinations for refugees in Southeast Asia, and a large proportion of refugees in temporary shelters, as well as urban refugees and asylum seekers in Thailand, hail from the neighboring Laos, Myanmar, Cambodia, and Vietnam. Even though literature is missing, primary sources indicate that there are LGBT migrants from South Asia, particularly Bangladesh and Pakistan, as well as from Malaysia and even as far east as Mongolia. And they largely fall under the urban refugees and asylum seekers category. Unfortunately, substantive disaggregated data and analysis of the needs of LGBT forced migrants is not readily available. A 2019 study among urban refugees and asylum seekers in Thailand revealed a large amount of unmet health needs. The Thai government has enacted policies such as the one-step services for unregistered migrants with dependents. As you heard, Alexa, the Thai government is not a party to the Refugee Convention. And as a result, it sees everybody as undocumented persons. However, the reach is not universal, with the largest proportion of unmet needs among the urban refugees and asylum seekers being from the Middle East and North Africa region. The limited literature from Thailand reveals that SRHR needs are largely centered around women and adolescent girls, especially those in temporary shelters, as opposed to the urban refugees and asylum seekers, and focuses in a large part on the reproductive health needs, such as menstrual hygiene, pregnancy, as well as childbirth. From the conclusion that I came to from reviewing the secondary literature that is available and a lot of sort of process documentation is that there is a lack of substantive disaggregated data, which is always helpful to sort of support our activism. So the first recommendation from this research is to collect disaggregated data on vulnerable and marginalized forced migrant communities and individuals across Thailand, with a focus on LGBT refugees and migrants. Given the increasing conflict in the region and the intractability of the global North refugee and asylum systems, it is likely that there will be LGBT forced migrants from Afghanistan and even farther afield in Thailand in the coming years. Further, the rise of anti-gender rhetoric is leading to pushback on LGBT rights and bodily autonomy and integrity globally, leading to increased violence and criminalization of an already vulnerable LGBT population, as well as, of course, the rights and bodily autonomy of women and girls. Thailand has a unique opportunity to anticipate and prepare for such needs by formulating and enacting best practices for the provision of SRHR services to LGBT asylum seekers and migrants. So my second recommendation based on the research and available literature is setting up a community of practice on SRHR service provisions. A community of practice with actors from across the health service providers, SRHR advocates, and forced migration-related state and non-state actors must be formed to formulate a coherent, data-driven model of addressing SRHR needs of LGBT forced migrants as well as women within the forced migration system. Prioritizing a goal of cultural safety, such models should incorporate existing best practices and recommendations from international sources. The principles of approachability, acceptability, adequacy, affordability, and quality, accepted to be a model in designing SRH services for vulnerable people, including migrants, must be centered in all such models. I'll just explain a little bit. Cultural safety is a concept developed by practitioners internationally. It's not specific to LGBT or to sort of women, but in contexts where we expect sort of people coming into the medical system, clinicians must be aware of the power differential and sort of be able to enact or make their practices culturally safe for those accessing the services in order to put the people who are already vulnerable and at a disadvantage at ease, so they are feeling sort of it's easier for them to access the services. One of the examples of this that UNHCR, for instance, gives is that a lot of SRH services are formulated around a lot of, heteronormative tropes. And as a result, a lot of transmasculine persons, non-binary persons, and, queer women are often hesitant to sort of seek help for their SRH needs. It is supposed to be sort of the same as, cis and heterosexual women. and often this deters these people who are extremely vulnerable from seeking help. And similarly, the principles of approachability, acceptability, adequacy, affordability, and quality, it comes from a model that was developed partially in Sweden. I mean, it has broader applications, but it was sort of piloted in Sweden with young, youth migrants. And this is something that had a lot of success in sort of ensuring that vulnerable people are accessing the SRH services. Finally, the service provision should be community-led and participatory. Community-led initiatives have proven to be the most successful, especially when it comes to vulnerable and stigmatized people. Such participatory approaches also have the benefit of having community buy-in. SRH services, therefore, should consult and involve the LGBT and women forced migrants themselves in designing such model and determining the needs and how services should be designed to have maximum acceptability and access. And this has also been sort of established in multiple researches, like community-led monitoring of uptake of SRH services. I can think of at least one community-led monitoring by trans people who are particularly vulnerable to HIV and STIs, which shows that often they're unwilling to access services even when there is urgent need because they feel stigmatized within the mainstream clinical settings, and a lot of them would prefer, for instance, community-led clinics that are providing these services. And Thailand is actually has a lot of good models in this regard. But they're not specifically designed keeping in mind people in the forced migration system. So that's it for me. I am happy to have a discussion and answer some questions now.
Thanks, Maddie. That was really comprehensive. I think she covered a lot of different areas. I don't know if anyone has any questions, any thoughts, any reflections, just as you're digesting everything that Maddie has just shared with us. But I want to open it up if anyone has anything that they'd like to say.
Thank you. Very comprehensive presentations. I was really interesting, but just you mentioned a lot about LGBTQI plus and also those vulnerable teenagers and young and HIV with the STI. I was just wondering because with discussion at our work, we try to. Actually, people had worked in 3 refugee camps before along the Thailand and Burma border, but we stopped because of lack of funding. But however, since the fight happened in Myanmar, so there is a non-registered migrant and refugees across the border. So we try to find a way to go back and work and support them on the HISR and to see how they can access to family planning and HISR service. You mentioned a lot about all those populations, but I was just wondering if this research cover women, pregnant women, people with disability. They are also affected this too. I agree with you that the approaches need to be integrated, the acceptation, the adequate and affordable, and also the quality of care need to be integrated in order to service. Maybe in some area or any other area that we can provide the comprehensive to all, not only for not only for those who has HIV, because sometimes when we talk about HIV, it's also discrimination, and we would try to even make them become more marginalized if we just focus on the HIV. So in this point, my point is I'd like to know from you if any research on pregnant women or other women that cannot access to SRHR in terms of their culture and their lack of information or lack of the accessing to the service. So 2 questions actually.
Thank you so much for that. Alexa, should we take more questions or should I respond?
Do we have any other questions? I think you can just go ahead, Nadi. Thank you.
Thank you for that. That's a very good question. So I should have given this disclaimer at the beginning of my presentation, but so basically I started from the point that a lot of SRH services that are provided focus on reproductive health of women and girls, including in Thailand. And in Thailand, the undocumented or whatever forced migrants are divided into people who live in camps and people who are urban refugees and asylum seekers. And these are 2 different categories. And by and large, what the literature covers is that there is some access to SRH services among the population, and I'm sure it is very inadequate, and there is lack of funding and there is lack of will generally in the system to provide comprehensive SRH services. But from the little that I can see, there is an understanding that the women and girls need SRH in terms of menstrual hygiene, pregnancy and childbirth, and so on. Where I was starting from, and for me, the LGBTQI plus populations, as I mentioned, also includes women or assigned female at birth persons at the intersection of multiple marginalizations who are left out of the system or are not considered, like, as I mentioned, transmasculine people, non-binary persons, and queer women. And that was sort of my starting point. Even if you look at the present crisis in Gaza, there is an understanding that the SRH services are missing, but it only focuses on pregnancy and menstrual hygiene. There's a lot of reports, and there's a lot of reports from UN agencies around these issues. But it's poorly understood, sort of the SRH needs of LGBTQI plus people and community, especially those in forced migration, often because some of them are in forced migration situation because of their identity, not just because of political turmoil in general sort of issues. So it needs a certain kind of sensitivity, and I think there needs to be a certain kind of sensitization in the system about these needs. I completely agree with you around HIV as another axis of stigmatization. My point was not to sort of further stigmatize people. In fact, I feel that service provision often focuses on LGBTQI plus people, only in terms of prevention of STIs and HIV. And I don't think that that's necessarily right because, you're basically reducing the population in some senses to, being carriers of certain kinds of virus or disease, and that's very unfair. I think SRH services generally only are focusing on preventative stuff for LGBTQI people, and it needs to be improved. It should be like, for instance, provision of hormone replacement therapy, gender affirming care for trans people. It could be sort of, issues around, the guarantee to have form relationships, found a family, etc. when you're an LGBT person. And all of these things and the sensitivity in the system is currently missing because there is a missing sort of protocol for these things often. So that's where I was coming from. My idea was not to, further stigmatize people by assigning, blamed for HIV or something. So point taken. Sorry if that did not come across in my presentation. Thank you so much.
Thanks, Maddie. Does anyone else have any comments? I was just thinking when you mentioned Gaza, it's interesting because I'm almost every day right now getting a message from UNFPA, which is the UN agency that leads on SRHR. And of course, it's a good thing that we're calling attention to what's going on there. But the images of what I see in their communications, it's almost always a pregnant woman and a child. So it's really focusing on these small aspects of SRHR when there's so many other issues that need to be addressed under the umbrella of SRHR. They don't talk about access to abortion, access to HIV medication, access to gender affirming care, or anything else in that kind of outside of that small siloed thinking. Yeah. That was just a quick thought. But does anyone else have anything that they would like to ask while we have Maddie with us?
Narut from JRS. Just a quick question. I'm just wondering, is there a way to get some more evidence, perhaps quantitative data that we could share with donors? Because as Alexa said, it's the whole universe of needs are so great. It's difficult to then advocate for something that's a bit that's part of that, right? So if we can get strong, I don't know if it's even possible, evidence, quantitative data. I don't know if that's even possible.
Yeah, I mean, for sure, there are some barriers to it, especially given the context where a lot of people face stigmatization and criminalization. They might not be willing to sort of come forth as specifically LGBTI. And I'm not sure what the approach should be. And it's obvious that women and girls are much more numerous in any population than LGBTI people. And therefore, I think it's okay that the focus is on their health, but it's also very limiting to focus only on, say, one of the things that I was thinking of, and there's been a lot of feminist critique of SRH services in practice about this, is that it focuses on, menstrual health and reproductive health. What about, for instance, older women and menopausal symptoms, for instance, that completely is missing from the entire literature and service provision sort of purview. I'm not sure what's the best way to go about collecting data about LGBT refugees, but there are some organizations that are approached, I believe, by people seeking asylum or using Thailand as a third country, and EAF will have a sort of better idea because they've already done a couple of research on this. So that is why it was my suggestion to form a community of practice, including, SRH service providers, advocates, government agencies, as well as, think tanks and LGBTQI organizations, as well as refugee and migrant-related organizations. But yeah, I don't think, I think it will still take time, but I think EAF's research forms a good basis for initial advocacy and for sort of the need for convincing people of the need for collecting this data more comprehensively.
Thanks, Maddie.
Thank you.
Yeah. We've got one more question coming.
I was just talking about data. Thank you for raising the issue about the data and more information. As we're working and we based on the evidence base and data, the numbers, I was just wondering, you mentioned that there is, in your presentation, you say that LGBTQI+, they are risky for the SGBV. Is there any data that you can give me the recommendation to look at it, or any organization that done some of the research in this issue?
I don't think So, yeah, I understand. I don't think there is a very comprehensive sort of quantitative data available on that. But you can look at the EAF research for, people's testimonies, for instance, around SGBV and the reasons why they were forced to seek asylum in a third country. But yeah, again, often quantitative data is what is missing. There is a lot of qualitative data available, especially from people who are directly working with either LGBTQI peoples or directly with refugees.
I think we're almost out of time, but if there's anything else anyone would like to add, there's also, a couple of minutes left. Otherwise, I just wanted to say thank you so much, Maddie, for taking the time to join us and for putting that all together and sharing it with us. It was really excellent.
Thank you so much.
Okay. We're now going to have a very small panel discussion, so I'm just going to invite our panelists to come up to the front. Kundream, Sanikan, and Supawadi. So we've just heard from our expert, Maddie, who's talked a lot about the gaps around LGBTIQ needs and services. We wanted to now focus a little bit more on the SRHR aspects. So we've brought 3 experts this morning who are going to share a little bit about their work with various communities within Thailand. And the different aspects of sexual and reproductive health and rights that they're all working on. I'll just go through a very quick round of introductions. We have from Rax Thai Foundation, Kundream, who is the program officer focusing on migrants and who is looking at the best practices for the healthcare of LGBTIQ migrant workers through a Stop TB and AIDS project.
Good morning, everyone. I'm Papaporn Chuet. I'm from Rax Thai Foundation. For Rax Thai Foundation, we implementation for Stop TB and AIDS, both of Thailand people and migrant people. For migrant people, we focusing on the migrant worker who are fishing, seafood processing, construction, agriculture, and general service, with both of undocumented migrant and documented migrant. For the Stop TB and AIDS, we follow the RRTTPR cascade. It prefer reach, recruit, test, treat, and retain them into service. The first R is reach. We provide TB and HIV information or education to the migrants, includes the and provide the necessary prevention package like a condom, like that. And while the recruits, we provide the mobile TB and HIV screening test for themselves. After we recruit them, we encourage them to test for TB and HIV by hospital, or we use HIV self-screening test. Yes, for we know them results. If some people have a positive result both HIV and TB, we will support them to enroll in the hospital to receive HIV and TB medicine. But because of some of undocumented migrants, they have no document for register for the insurance enrollment, this is our gap of healthcare provider. But for some people, if they don't have money or to for travel to the hospital, Rak Thai Foundation provide the living support as well, like travel costs and some of package for them. After that, we will providing prevention for the HIV and TB as well. For HIV, we have to provide the PrEP. Now we provide PrEP to the MSM for Thailand women, for Thailand people, but for migrant people, we cannot provide because of insurance. Yes. If migrant people need PrEP, they need to pay by themselves. This is a gap of our work as well. And for the TB treatment, Thailand physical don't need to provide TB treatment to both of Thai people and migrant because of they don't know too much about this prevention, but from the guideline they can provide it. Yeah. After we treat them and provide them to the hospital, in the community we have a health volunteer and field coordinator to visit them and follow up them to HIV and TB adherence. For TB, we have like a directly observed therapy by see them to each day by day for TB therapy. And HIV, we adherence for the medicine taking and follow up them for the CD4 viral load. Also, we do the case management to the migrant who is people living HIV and TB. Yes.
Thank you. I think we've already just started diving into things now and hearing about some of the gaps around HIV and TB treatment for migrants in Thailand. I think we'll move on now to Supawati Tongrit, who is the project director of the Urban Refugee Program at the JRS, or the Jesuit Refugee Service. So we'll now move on to hearing a bit about the context for urban refugees and the work that you're doing with them.
Sure. Thank you very much. So again, thank you for having me here. We're from JRS, Jesuit Refugee Service. So we will provide service to urban refugee. This is including asylum seeker, closed case by UNHCR as well. There is a limit number during this year for LGBTIQ communities. As you guys know, as the panel also know that UNHCR tried to urge the case to get a resettlement a lot through 2018, 19, and until now. So for now, I can say we have less than 5 regular clients under JRS. Recently, we received 2 from China as well. So we try to explain and also ask them what they really need. So we provide the basic needs such as a shelter, emergency shelter, food, medical if they need it. So as I said recently, that 2 cases came and they said they are homeless. So what JRS can do is provide a shelter. We have emergency shelter right now, only 5, and most of the time are full. So we try to explain to the client and as well as to our partner that this is temporary, meaning they can stay for 1 month. After 1 month, then we have to ask help from the partner or find solution for them. So this is temporary, as I said, and it's also not a safe house. So we also explain to the client, meaning not only the urban refugee, but also a Myanmar cases, that you stay there, please don't assume that it's a place that you can feel safe, but it's not safe as such. Immigration can come in any time, so please be careful whenever you go, wherever you go. Please be with your community as much as you can. And talking about the LGBTIQ+, JRS trying to have an orientation to our own staff to understand who they are, how can we call them. Some people, when they come to reception, they wouldn't want us to call them Miss or Mr. They just want us to call them by name. So we respect that. So every time when the new staff come in, we have that orientation, explain them what is the situation of LGBTIQ and how the JRS can help. And also we're trying to make a safe space for them by giving them some time, if they need a room to stay, not to be mingled with other community at the reception. We also provide that to them as well. And also not only staff that we have an orientation to, but to our interpreter as well. For some cases, they cannot speak English, of course. So the interpreter need to understand the situation of LGBTIQ refugee, who they are, how we are, and what sensitive issue that we should not talk further. So we do that as well. I think right now we try to help as much as I can, but maybe not fulfill what they need. Why I said that? Because what they want is not only the rental or shelter or food, but they need medical support. So the hormone treatment is very tricky right now. I used to work along with Red Cross, if you know, next to Chulalongkorn University or hospital somewhere. So at that time, we had a lot of ideal plan, but it doesn't seem to be work. Like it's flop. It's I would say it's not working. So I'm not sure how we are here can help them in those area of getting hormone treatment, because that needed. Yeah. That's really needed. And also access to health care is very, very important. Oftentimes, they came back to JRS and said, that hospital doesn't receive me well. The staff doesn't really talk to me as a human being. They need a Thai staff to come along. Then they will not give me a queue or a chance to see a doctor. So that is a very, very important. Medical is very important. So what JRS can do is provide interpreter if they need it, but they have to come and tell us. They cannot just call us when they are in Rajadviti hospital, hey, can you come? So that we also inform our own staff that if you receive LGBTIQ client, please inform them. If you need interpreter to help you during medical, seeking medication, please inform us earlier. We can help, we can support in that part. And also we can provide the medical reimbursement as well. Yeah, case by case.
Thank you. So you've mentioned, just quickly as an add-on, you mentioned hormone treatment. What other kinds of health needs are you seeing your clients come in with?
So for some cases, I'm not saying all the cases needed. Some cases they said the progesterone that they have to take it every month, and it's not cheap at all. So that's what I mean.
Okay.
Yeah, the estrogen and progesterone is very important for them. Yeah.
And it's not covered?
No, it's not covered.
Okay.
Yeah. I think right now Tangerine under Red Cross is trying to, but not for everyone.
Yeah.
I think they also have a limitation as well. Yeah.
Okay, thank you. We'll move on now to our third speaker, who is coming from the Planned Parenthood Association of Thailand, Kun Sanikan Rosemontry, who is the Research and Program Development Manager there. And I think they will talk a little bit about some UPR findings that PPAT undertook.
Hello, I'm Sanikan from PPAT in short. We work in the field of sexual and reproductive health for a long time, since 1970. We cover many population, and today I would like to focus on only migrants. We work for migrants in the field for several years, and many of program focus on to give their information about the SRH to provide service. The programs such as promotion of HIV testing and AIDS treatment in TAC, and pilot end-to-end referral system increase female migrant workers to access comprehensive abortion care and fisherman's life enhancements that we provide education for the migrant children. And we also have another program that we try to improve the sexual reproductive health and service for the worker in latex factory in the south of Thailand. We worked for several years, and we reached out for over 20 people, and we realized that we need to do advocate for migrants to get more access to the SRHR, because we found out there are several barriers that migrants face. For example, the status in Thailand for the accompanied person that come with the migrants, only under 18 years they can register. Other that they cannot, so they will not get any benefit for help, and some financial barriers that they have very low income, and also there are only two kind of the service provider, insurance service, like social security and insurance that they have to buy by themselves. And also there are many unmet need for information, education, and family planning service, especially during for the young people. So that we work with the IPPF to submit the UPR shadow report to advocate for better sexual reproductive health and right for the migrants. And yes, that's what we did.
Which communities of migrants was your report focusing on specifically?
The report is we focus in general migrant in Thailand.
Okay.
Yeah.
But it was also, I thought you mentioned some of the communities were by the Cambodian border, for example, and in the south of Thailand as well. Is that right?
We mostly we give some example from what we work with, the group that we work with in Thailand in the south, and we also work with the refugee in the border of Thailand as well. Okay. So in this case that we developed the UPR report in support by the IPPF and submit to the advocate with the expert human rights in Geneva in March. We prepare for about one year to advocate on this, and then we talk with expert in the government sector, and then they can help to voice our need in the UPR in November that the government present and get some kind of peer-to-peer suggestion, something like that.
Amazing.
And you want me to continue for the information, or?
we can just take a quick break. So I think from all three of our speakers, we've started kind of unpacking and better understanding what some of the key vulnerabilities and barriers are for them to achieving, fully achieving their sexual and reproductive rights. I mean, we've heard a lot about, I think all three of you have mentioned the financial barriers, that they're not eligible for any of the insurance schemes, and the out-of-pocket expenses are probably unattainable or too high for many forcibly displaced persons. We've also heard you, all three of you, talking about sort of the stigma and discrimination that they are facing as well in different settings, but especially in the healthcare settings. I think I wanted to move now just to ask each of you, thinking about this and thinking about the communities that you've been working with, what recommendations would you have to ensure that they can access their sexual and reproductive rights specifically? Do you have any recommendations on how we could start to fill these gaps? And you can make recommendations either to what you think your own organization should be doing, what NGOs should be doing, or how we can work together to also advocate with the government and what you think the government should be doing. So let me switch up the order, and let's start with Supawati. Do you mind going first?
Sure, no problem.
Okay.
Yeah, so I think, so if we're talking about reproductive system or health, one thing I'm thinking is the educations. Not only education to staff that I mentioned earlier, but education to the LGBTIQ community as well. So when we're talking about the sexual health or reproductive health, we are talking with both, not only physically, but mentally as well. So I think education to provide to LGBTIQ community is also not thinking about only the, not to get the disease, for example, but thinking about the positive, to be a positive sexual relationship as well. Yeah.
Dream, do you want to help share?
Yes.
Go ahead.
From my opinion and from my experience, my migrant worker who are LGBTIQ plus, the problem is from their own culture and their own belief that they can reveal their status to family, and they will by the close friend, and that's why we cannot reach them into the healthcare, because we don't know their status, and they don't tell me directly. We need to observe them for a long time to know what their status. And the most gap of for the health, migrant and refugee into the healthcare is the right of them to for the who don't have a document, they cannot buy a insurance. If we can sell the insurance with if they don't have document, we can provide a health insurance for them. They can access to the medicine and medical. Yes, but for Thai Foundation, we have a community health volunteer and field officer to get along with them when they go to the hospital. But some like Kun Supawati said that some of health provider, they have a stigma and discrimination to the migrant worker. But if they are a migrant worker, they have a tough to communicate with the Thai people and nurse, right? We will skip them to the last queue. Yes, and they need to have a translation and or translator, like Kun Supawati mentioned. Yes, and why we support them for the living support, but it's not sustainable because the gap is, as I mentioned above, this is a health insurance for them. Yes.
Thank you. Okay. And Kunsanikan, what would your thoughts be? I know you have a lot of strong recommendations in that UPR report as well.
Yes. May I ask if anyone involved engaged with the UPR report some time ago or this time to advocate in Thailand, Thai government?
Quick show of hands, how many people know what UPR stands for? So it's called the Universal Periodic Review Process. And it's a human rights mechanism in Geneva where all governments, their human rights records are reviewed every 4 years. So civil society can develop shadow reports as part of this process and submit it when they see human rights violations happening within their country. It's a place to take forward human rights violations. It's a strong mechanism. Yeah, go ahead, sorry.
Yes, just to ensure that if I explain good or not. For the UPR report, actually we asked the government to talk on our behalf at the UPR Thailand when they report later in November. We prepared in March last year and then report later in November 2021. And our recommendation at the human rights expert that we advocate them to talk on our behalf is about to develop a national plan to guarantee access to SRH service for all, including regular and irregular migrant workers. And also we would like the government to guarantee adolescent SRHR through multi-sectoral collaboration. So at the meeting, and we found that many government support us, fully support talking on our behalf on SRH that we advocate to them. Mostly they are Uruguay, Malaysia, Canada, Sri Lanka, Vietnam, Bangladesh, and Iceland. And some other government, they talk in relevant issue on the SGBV, sexual orientation and gender. They are Fiji, Mexico, Argentina, Israel, Chile, Finland, and France. And finally, the government, Thai government, they give very positive side to us. They're willing to support it to further develop, to help migrant, refugee, and asylum seekers. For final outcome, generally, for the migrant, refugee, and asylum seeker, they would like to further promote the rights of migrant workers by guaranteeing their access to essential service. The government also would like to take all necessary steps to immediately end forced labor and human rights abuse in the fishing industry. And also they would like to implement the legal measures to ensure proper protection of refugees and asylum seekers. And in terms of the right to health, in terms of the reproductive health, they're willing to implement measures to provide to provide non-discrimination and to ensure that USC cover to everyone, including for regular and irregular migrant workers. And another thing is about in education. The government will continue to promote the right to education for all, including the member of ethnic groups and foreign and migrant workers, children as well. So this is the key point that very important to our works. And I would suggest we may work together, and also we can also follow up with the government to see how the progress that they commit at the universal periodic review platform. Yes.
Thank you. That's very good results. And that's already, I mean, the first step is when you get the government to agree that they need to do something. And then second step is to make sure that they actually do what they say they're going to do. So maybe that's something that the others that are here can also help with, right? Following up. Thank you. So can we just say thank you to our speakers? Just like maybe a big round. Thank you. We've put them in the hot seat a little bit, quite literally. It's a bit hot with the lights coming. But we want to open it up now because I know everybody in this room has a lot of experience as well and has their own thoughts. So I wanted to open it up for any questions that you might have, either for the speakers or you can also share a few reflections or even recommendations from your own work around SRHR and forcibly displaced persons. But if we want, should we come and join? We can come and sit at the tables again. Maybe that's a bit more comfortable.
I would like to share my experience of working with the LGBTQ as a frontline officer. Yeah, another barrier or challenging of working with them is about the safety. Some of the LGBTQ clients they come here seeking an asylum to Thailand because of they got harmed at their home country. And then they come here to Thailand, and some of them like got harmed again with in the apartment. That's why they would like to seeking another apartment for only women. The challenging is that it's for their safety. That's why sometimes for women apartments it's sometimes get high price for their apartment. And also need to negotiate with the apartment owner as well about her appearance and why they need to rent the apartment. That the solution that we are trying to solve is that to understand more their situation and be aware of that and concern and provide a proper service to them, and understand about the safety of them. And if you have any more suggestion to me, feel free to let me know about that as well.
So what Billa was talking about is some cases they live with the family, and after some time, of course, the families encounter or find out that they're not straight person. So the discrimination among the family is also a very, very important for not us to work on, but how can we? Because we also don't know where to exit. If the family themselves doesn't receive them well, how can we? So in the past, I can say from my own experience as a psychologist before, there's one client came to me and she got bruised everywhere, was beaten by her own brother, not father, brother. And then what we can do is, at that time, the basic needs is very important. Find the shelter immediately. So the EM or emergency shelter that we provided to the person usually is temporary, meaning 1 month, and then we have to find another solution. But that client, we are helping the person for almost 3 months continually. Luckily, she got a chance to go to Australia. So I can say from my own experience, it's very important for family to understand, and very important for communities to understand their situation as well. And this is often happen with Ahmadi, Muslim.
Thank you.
So just to add to that, basically GRS Thailand, our urban refugee program, it's the services we provide to the population here. It's general, right? We're not a specialist agency dealing with domestic violence or SGB. So this is the challenge we have. We can, but sometimes we don't. You know, but it's a limited number of agencies who do this thing.
To ask Kun Prabhaporn, Kun Dream, about the PrEP and PrEP. Is your organization providing the medication directly to the client?
For Stop TB and AIDS, we work with Thailand people as well, and we have a community led to provide PrEP to Thai people. Yes, but this is our partner and our network to provide them like I'm not sure their organization, but it have a pilot our partner to provide them for PrEP. But for migrant worker, we don't have to provide them by ourselves. But we prefer and refer them to hospital if they need to receive a PrEP, but they need to pay by themselves. It is yes, but that's why they cannot receive PrEP by themselves because of they need to pay it by themselves. But we also provide a condom for prevent HIV to them. Yes.
So now we're talking about basic needs like food, shelter, place to live, whatever. But it's also JRS are trying to, as Kunarut said, we provide to all general population of refugee and asylum seeker, including closed case by UNHCR. That is go to casework, under casework service. But we also have MHPSS mental health service provided to refugee, to LGBTIQ as well. So in 2018 and 19, there was a continuing group support activity called Yes Queen, You Are Queen, provided to them. At that time, I think we have just 6 people for the group support, and it was very, very successful. They are sharing about their idea of how Thai people, the languages is very important. Some people also learning Thai very quickly. So, and also some came here before. They also are providing more information of the health support from each organization. So that's really, really successful. As I said, for this year, we have a very limited number, but we are thinking, of course, with the psychologist team also to continue doing this again, hopefully coming years. Yeah. And also most of the time, they are, for example, as I said, for Ahmadi, they are Muslim. And when the parent file out or the community leader file out, they always got kicked out from the community and they've been isolated. So our psychologists are trying to either on call, like on online counseling or in-person counseling as well. Yeah.
Yes, please. The reason I asked, I just like to share because we try to establish a new clinic to provide PrEP and PrEP for the refugees and migrant worker. But what we facing, the challenge that we face is that the government will not allow the NGO to actually open our own clinic even though we have our medical doctor. maybe this issue can be expand our work on the advocacy work, because that's why I asked Rakthai if Rakthai coordinate with the Thai government or coordinate with the NGO organization that working on the health, because as PPAD we cannot do it. We try because we receive funding to do research on this, and also that funding from the IDVF actually, so like they want us to try on the biomedical prevention, but in Thailand we cannot do that because we are NGO. So with my colleague we were talking about if maybe some of the mapping of the work that doing the work on the HIV and STI preventions, we can do the mapping with the other NGO and come up with some document or something and propose to the Ministry of Health or the CDC Ministry of Health, asking if there's a challenge of the refugee and migrant accessing to this, because they cannot walk through the health center of the Thai government hospital, but they will be comfortable to come to us. Right? So I think maybe some the area that we can work in the future.
So a quick question, because we've heard about eligible support, we've heard about access to PrEP, for example. But what about things like access to medical abortion? Is that something?
Okay, for medical abortion, right now, for the unregistered migrants cannot access to the USC. But however, other Thai can access to the USC, and medical abortions are also including in the USC. We had a program a couple of years ago that we provide assistance for migrant workers from Myanmar and Laos and Cambodian who are working along Samut Sakhon province. Then they can call us and we provide counseling through the hotline call center 1452 in their languages. However, when the project ends, we propose this to the policymaker, and they say it should be included, but we cannot have the services, like one-stand services that can provide only these 4 languages. So what we try to propose next step is, if not through the hotline call center, maybe we can work together in somehow, because some of you may have staff that who can speak Burmese or speak Korean, speak other languages, but we can't. We only speak Thai, but we can assist in helping them access to safe abortion care. Both medical and medical abortion and medical vacuum abortion at our clinic. But however, it depends on choice. We try what we do, and we ensure that they gone through the optional counseling before they make their decision. So the staff who can speak their language need to go through the training, which is not easy for us to do the training for them. So I think that's another like challenge that we're facing right now, to expand choices for them.
Yeah, I can add a little bit more about the medical abortion. Personally, I used to work with at least 3 clients for the medical abortion, and I agree with Kun Nantakan. Another challenge from our side is, first we start from our own perspective on the abortion. Yeah, this is a big challenge because if we have a bias on this, we will be reluctant to serve them, which they also need our service on that, because we have to be like translate anything else, assist them to access the medical abortion, safety medical abortion. We in Thailand, I believe we have a legal abortion now. Yeah, but it's still hard to access for migrant or urban refugee and asylum seeker. I personally, I have to do it low-key with the private sector of the medical abortion, which costs a lot of money. At that time, I have to personally ask the officer to do some pro bono for my cases. And other cases, I have to contact with international organization for the service, which is cheaper, yes, but it is also more risk because they only provide medicine abortion, which the client have to do by themselves at home. Yeah. So in that case, me as a psychologist, I have to closely monitor with them, both on physical health and mental health. They are reluctant to do it, of course. Yeah, they are not like happy to do it, obviously, but they have to do it for their own sake, for living in Thailand, which is hard enough for them. So yeah, if we could have like more mapping or service that we could share within our NGO or organization to provide more accessible for medical abortion, that would be great. So needed is open heart staff and translator. This is important. Yeah. Thank you.
I'd like to add is we also right now we also have the telemedicine to provide medical abortion for those girls and women who need to seek safe abortion care. We have a medical doctor who will provide counseling and consultation as well. But however, we only do it in Thai. So if for migrant workers or refugees who need to access it, they need a translator and interpreter through, because we need to ensure that their choice. Only Thai right now. Only Thai right now. Also Russian. Russian. Because the doctor is in Phuket. Yeah, he's also English. He can do it in English too.
At least you have the translator. Actually, we can help. Yeah. Mostly we use the AI to translate in any case. Yeah. I mean, like, it's not very good.
Sorry, you mentioned the translator. I just wanted to know if there were also things for access for disabled people in terms of like sign language interpreters or other facilities like that, because like obviously there is an issue when like conflict and war happens and it's mass disabling, right? Especially during COVID, we had this issue. But there are also refugees who are disabled, who are hard of hearing, deaf, who use sign language as their main language. So are there also facilities that that have these things in place for them?
Can I repeat your questions? Right. So is the so you were asking if any services or any interpreter that
So
available
yeah,
right
just
now?
for any information, are there interpreters? So for example, for counseling, right?
Right.
Are there interpreters for sign language? Because obviously, when someone, for example, a deaf refugee would go in, or hard of hearing refugee would go in, and they would access these healthcare services. But how are they going to communicate? Are there also campaigns or facilities in place that provide sign language interpretation?
Okay. So let me answer you with 2 points. First is for the safe abortion care. For the safe abortion care, we have both an in-clinic safe abortion care, both medical abortion care and medical vacuum, which is we provide at our clinic. Is also we mailing. There is a system on the web application that you can contact us. through the telemedicine program. In the telemedicine program, the doctor will using the AI to translate it. But however, we have Burmese volunteer who can speak Burmese and Thai and English. She's actually our volunteer. She did not work for us, but she's really helpful, especially during the COVID-19 pandemic. She have her phone ready for 24 hours, and then get people who call us, and if we cannot communicate the message, we go directly to her, and then she will try to help them. And she also is trained on how to do the counseling for the safe abortion care and also HIV counseling. So this all we have, the service right now that exists.
Okay, so from my understanding, there is a gap, right?
Yeah.
So there is a gap where we have all of these translations available, except of sign language, or the gap is that it's not accessible for disabled refugees, right? Are there plans in place? It's not just for, this question is not just for you, but like for everyone in the room. Are there plans in place to actually change that? Where we're actually getting volunteers in who actually know sign language, or even closed captionings while doing telemedicine, because that's a very important thing, right? I don't know if there is anyone in the room who would be able to answer to this, but if there isn't, this is a gap that we can move to fill.
I can just chime in very quickly here. This is Ryan. Can you hear me? Hi, so the UN.
Hi, Ryan, we can hear you. Go ahead.
Sorry, I'm in my pajamas, so I'm not going to turn my camera on. So UNHCR has this approach called as the age, gender, and diversity approach when developing pledges, multi-stakeholder pledges for for the Global Refugee Forum. So I think it is useful to kind of use that framework to kind of understand how we are providing services for LGBTI persons, including SRH services. So using that intersectional lens of age, gender, and diversity, you can find that on the Global Refugee Forum website, and see how we look at disability, ethnicity, a whole range of intersecting and cross-cutting challenges that refugees and forcibly displaced persons might face. So this is just to kind of add to the conversation to say that it is being considered globally, as well as countries are encouraged to use the AGD approach to address all these what I earlier mentioned as multiple and intersecting vulnerabilities of LGBTI migrants, refugees, and forcibly displaced persons. Thanks.
So for anyone online, we're actually taking a 5 to 10 minutes break, and then we're gonna come back.
Shane, could you also organize for a picture?
Actually, before we go on break, could we get a group picture in front right here, please? Thank you.
If our colleagues at the tech desk can put up the slide of the event on the background, it would be great.
Can I please request everyone to come in front of the room so that we can take a group photo, please? The sooner we get this done, the sooner we can go back to conversations. Everyone, if we could just come back from the break, thank you so much, and we will get the next session started. I'll just wait for everyone to get seated, and then I will introduce the session to us. So the next session requires a little bit of group work. So find your places and find your group. So we're going to do a little bit of a mapping of what is already out there, what we think should be out there, and what is already being done to bring it out there. Yeah. Is the water dripping? Oh no. Let me try to get someone. Yeah. Okay, so while they're fixing that, I'll just go ahead and introduce it. So, for LGBTIQ and women refugees specifically, in terms of SRHR, we're going to map out what campaigns and what do you call it, programs that are already existing in Thailand specifically. So try to focus on Thailand as much as possible because that's what we're trying to do, right? It doesn't matter whether it's for urban or camp refugees or border refugees. Just try to focus on what already exists, what we are hoping to see exist in the next 5 years, and what there aren't plans for programs to exist already, but what we want to see exist, right? Does that make sense? So we're mapping out 3 different things: what already exists, what is going to exist, and what we want to see exist. I will share out these little pieces of paper. You can also do it like on your computers if you prefer. I also have pens here. If you want to join in on this group, and then we can maybe break it down to 2 different groups. If you want to join in on that group, and then we can have you 2 join in on this group. How's that? Yep. Perfect. Okay, so also just an update, you have 30 minutes to do this, so we don't have unlimited time. Yeah, and then we'll do a quick report back for 15 minutes after that, so there are only 2 groups, so we'll do that after. So volunteer 1 person from each group to do that for us, please. Thank you. Just a reminder, we have about 3 minutes to go. There's a clock on right there. And also please volunteer one person from each group to do a recap. Yep. Do we need extra time? Yeah, both groups are ready? All right, fantastic. Can I get maybe one person from this group? Let's start with this group first, you're closest. Who's gonna present? Anyone can volunteer? Yep. Fantastic. So we've got a presenter from this group. Let's hear it.
So our group have like 5, 6 organizations. Sorry. So from the Thai, they already have HIV, SI, and TB program for LGBTQI+, and for youth lead organization, they have SRH, I'm sorry, like, and teenage pregnancy, and young tea population for LGBTQ+. Yeah, and for PBAT, they have like, do you want to present?
We do the safe abortion care through clinic and telemedicine in all 4 regions of Thailand. We provide family planning to LGBTQI and refugee and migrant workers. You may questioning why LGBTQI need a family planning. We all need family planning. So and HIV vaccine, HPV vaccine too. Contraception, contraceptive no plans, contraceptive pill, contraceptive injections, HIV screening, and referral for antiviral care. So we do with 3 of the populations LGBTQI and refugee and migrant. For the refugee, we work in Mae Sot and Mae Hong Son, Mae Lam Ma Un and Mae Lam Ma Luang. For migrant worker, we work around Bangkok and Samut Prakan and Samut Songkhla.
And for Host International, we already have a case management program and community engagement program, which case management, we also work with like like all the refugee and asylum seekers, no matter like their genders or like ethnicity, and also community engagement as well. But mostly we focus on the like mother who live in Bang Yai community. Yeah. And what we think the gap that we want to fill for Lak Thai organization, they want to reach out more LGBTQ plus into the RRTTRP. Yeah, and review people to the healthcare and officer with the close relationship. Okay. Okay, because Lak Thai is not here. Okay. And for youth lead organization, they wish to feel like mental health issue and wish to the teen training. Right? And for Host International, we want we still need the youth led groups, yes, and also mental health service that we want our organization to work for them, yes, and for PPAT.
We would like to open a new clinic for LGBTQI plus who need hormone and also the relationship counseling for the healthy relationship for other two, not just for the LGBTQ. So and for the refugee, we going to provide minimum service, minimum initial service package to the refugee in the area. For the migrant, we wish that we can expand and overcome the language barrier. Yeah. So I have still no plan. No plan on how to implement that, but we would love to hear from you too.
And the last topic, what we want to see in the future for Lak Thai, they want to reach LGBTQI plus to the healthcare service, and for youth lead, they want to escalate the mental health and AI to focus on the mental health problems through poor HR, right? Okay. And also, okay, do you want to present it?
Okay, so what do we want to achieve in your near future is mental health and AI together so that we can focus on mental health problems through poor SRHR problems, and maybe mobile health clinics that can focus on SRHR problems and have trainings on how we can reach to vulnerable populations and have community outreach as well as access to SRHR informations for teen and young key populations. Yeah.
Okay, and for Host International, like I mentioned earlier, that we still need a youth-led group to work with us. So what we want to see in the future, we want to see youth that can be leaders and voice for the community, especially on the LGBTQI plus as well, and domestic violence. And also we wish to see refugee can, like everyone, any refugees and asylum seekers can access to the education and language learning service. And also we wish to see them like that they are able to stand by themselves, like to receive like the like income generating opportunity. And for PPA LGBT. They want to see like they want to have to see the LGBTQI plus counseling and more inclusion, right? And also want to see incentives for. Oh, okay. Okay, so this is our group.
Perfect. Thank you so much. Now we're going to move on to this group. Try to speak into the mic so that people online can also hear. Thank you very much.
So for our group, we have been list out some organizations that we know already exist, such as SOGIESC, JRS, and BRC, which is a well-known organization for urban refugee context. SOGIESC is, I could say, the main responsible organization for medical health, yeah, including physical health and some service of mental health. For JRS, my organization, we do have some focal person for SGBV and LGBT clients, yeah, including UEP, which we are provide education for clients as well. And BRC, Bangkok Refugee Center, which is the affiliation organization with UNHCR, yeah. And some public hospital in Thailand also provide service for urban refugee and migrant, such as Ratchavithi Hospital or Police General Hospital, but under the condition that they have to be coordinated with NGO first, so referred by SOGIESC or BRC. And the service that already exists is also include mental health service provided by SOGIESC, which is provide a medicine, yeah. And JRS and BRC, we provide ongoing counseling service for client, also specific for LGBT if they request it. And we also reach out some private clinics such as Tangerine Clinic, Swing Organization, Red Cross, which we heard that they serve the LGBTI people, and hormone treatment. And the organization I personally just know today, PPAT. Nice to meet you. And UNHCR also provides some specific service for LGBTQIA plus people under protection team, but they will discuss like case by case. In camp area, we have IRC, Malteser International, DAR there, drug and alcohol rehabilitation education, I believe, and Metal Clinic, which they serve like refugee in general, but it is also include LGBTQIA plus people. Yeah. What is going to exist? We list as Bangkok Metropolitans also plan something for urban refugees. Is that correct? And also TBC also planning to do more survey in the refugee popularity. And M-Fund is the project they are on process about providing an insurance for urban refugees that could help them support a medical service. Anyone would like to add on this? No? Okay. So we move on what we want to see in the future. In the future, we would like to see more specific service for LGBTQIA plus group, such as like physical and psychological need, because we know this group have some like specific need in case of physical health and of course mental health. And it could be better if we can provide more legal service for their concern, yeah, and also advocacy for their issue as well. And also basic education access for LGBTQIA plus group, which they are more risk and vulnerable for discrimination in the school, of course. And we are expecting to have more data about camp refugees, and could be the best if we could have the inclusive service that we don't have to label any people anymore. Yeah, that's all for our group. Thank you.
Check. So I can add a little bit more from JRS. So just spoke with PPAT, and of course you guys know PPAT's advocacy kind of idea and perspective. So we also thinking of having a training to a community leader. As I mentioned to PPAT and other people as well, that Muslim community is very, very important, that we would like to work on it. This was in our ideal a couple of years ago, but we cannot complete it during the COVID time because it's online, and we would like to see them in person. So if we could start, if JS could start, then gonna be with Amhari community first. To change the person mindset is very, very difficult. But I think us should not stop by thinking of, or maybe imagination, like, okay, if we go to this community, we will not give any knowledge, or they will not receive anything from them. I think we should initiate something, even though they are having a bias in their mind also, but I think we could start, and we have resources to do it.
Great, fantastic. That was really, really productive. If you could get the notes from each of your tables so that we can keep them, and then perhaps make a report and send it out to everyone who has been here, that would be really, really good. I'll go around and collect it. Alexa, you want to take the mic from me then?
Okay, it's on. Yeah, thank you so much, everyone. I heard a lot of really great ideas and great discussions happening this morning. I just wanted to say that this is the first of 2 consultations that we will be organizing under this project. So this consultation was focused on community and community organizations that are working with communities. And then the second consultation will be trying to engage some government stakeholders, so we can take some of these reflections and ideas that you have to them, but also try and bring on board the government and get their own commitments as to how we can help bring this forward. And then the output will be an SRHR advocacy tool for use with organizations that are working with urban refugees and LGBTIQ+ and women refugees in specific. So that will be the final outcome from the project. But I know that Ryan also mentioned earlier, this is part of a bigger part of their work as well, and he's looking at how they can bring this forward at the global level too, through some of the global UNHCR processes. So I think this was a really good start this morning, and I hope that we can continue these conversations and continue bringing you in and bringing your thoughts in and getting some feedback on the work as we move ahead. So we'll keep you in the loop. We have your emails now, so we can keep you updated. And I don't want to keep you any longer because I think they're serving the lunch. So if you're hungry, you can just go and grab a plate and continue the conversation. Thank you.